Welcome to Morning Commute, improving early identification and treatment of hereditary angioedema. In this episode, On the Horizon, Emerging Therapies for HAE, Dr. Mark Rydell and Dr. Alina Banerjee take a look at some of the exciting new and emerging therapies for hereditary angioedema. This independent CME-CE activity is supported by an educational grant from Ionis Pharmaceuticals Incorporated. Information about the faculty and disclosures can be found at morningcommutepodcast.com/HAE4. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Rydell is a professor of medicine and the clinical director of the Angioedema Center at the University of California, San Diego. Dr. Banerjee is an associate professor of medicine in the Division of Rheumatology, Allergy, and Immunology, and clinical director of Allergy and Clinical Immunology at Harvard Medical School in Boston. I am your host, Candace Hoffman. Dr. Rydell will begin our discussion.
Welcome back to the second podcast in this series. And Dr. Banerjee, thanks again for joining me. In our last podcast, we discussed the diagnosis of hereditary angioedema. So recognizing it in the clinic, making the diagnosis. In this podcast, we're going to turn our focus to emerging therapies for hereditary angioedema. In order to start the discussion, I think we probably should cover a few notes on how do we manage HAE currently, what's the current standard of care and the goals of treatment. And so, Dr. Banerjee, to kick off, do you want to outline quickly for us, how do we set up a management plan currently for patients with HAE?
Thanks, Dr. Rydell, and it's great to join you again. When we talked about treatment 20 years ago in the United States, I think that there was very little that we could offer patients. And we're able to have the conversation today because the field has moved so much with 8 FDA-approved therapies, which really have changed the standard of care and the quality of life for our patients. And so in the broad goal of treatments, we break it down into on-demand treatment, which is really about using treatment at the start of an attack to prevent that attack from getting worse. Second is long-term prophylaxis, which is really about taking regular treatment to prevent attacks from occurring in the first place. And then a smaller bucket that we tend to not focus as much about, but is just as important when we're talking about treatment, is what we call short-term prophylaxis. And this is about taking treatment prior to a known trigger, so such as surgery or dental work, where we know that those types of things can trigger an HAE attack, to use medication in anticipation of that to prevent the attack from occurring. And so maybe to put that all into context, there are guidelines for the management of hereditary angioedema. There are US guidelines written by the HAEA, which is the Hereditary Angioedema Association. There are European guidelines, there are Canadian guidelines. But when you look at kind of the core principles of these guidelines in the context of approaching treatment, there's some basic principles that are very similar. For example, all patients should have on-demand treatment. They should have at least 2 doses of on-demand treatment. They should use that on-demand treatment as soon as they recognize that they're having an attack, because that's what's going to that's what's going to prevent that attack from progressing and prevent the long-term impact over the next few days. In terms of long-term prophylaxis, again, similar concepts. Every patient is eligible for long-term prophylaxis. Every patient should be considered for long-term prophylaxis, and these conversations should be discussed every time that patient is seen in clinic. And really, there's no one-size-fits-all. It's really about taking into context where's the patient's perspective and how do those fit into the treatments that are available. And so maybe, Dr. Rydell, I'll bring it back to you to talk a little bit about how you think about a therapy plan in the context of the goals of treatment.
Thanks, Alina. Yeah, so the first step, as you mentioned, sitting with any patient with HAE is to set up that on-demand or acute treatment plan. And this is without exception. Every patient needs rescue or on-demand treatment. just because these attacks can be unpredictable, they can be both disabling and very dangerous. And so we want to make sure patients are prepared to treat those attacks. As you mentioned, we have some approved on-demand rescue treatments for HAE. There's actually 4, 2 IVC1 inhibitors of various varieties, and then 2 subcutaneously administered medicines, one that blocks bradykinin effects and one that blocks kallikrein activity. And so as you noted, it's individualized. We choose an on-demand treatment for each and every patient. We make sure they know how to use it, when to use it, how to refill it, and so forth. The other treatment strategy that we're using increasingly is long-term prophylaxis. And as we move to talk about the emerging treatments or investigational treatments still in development, there's been a lot of action in the long-term prophylactic space because we are seeing more and more patients benefit from long-term prophylaxis. We've mentioned in other podcasts the unpredictability of HAE, which is a real problem. These attacks can be triggered by certain events or certain medications, but most of the time, these are unpredictable. There's no discernible trigger or reason for the attack to occur. So predictability has become a bit of a buzzword with treatment. We like to make life predictable. We like to prevent attacks if at all possible. We do have some effective long-term prophylactic therapies. These include, again, C1 inhibitor replacement therapies given IV or sub-Q. They include a monoclonal antibody, lanadelumab, that can be given subcutaneously every 2 to 4 weeks to prevent attacks. We now have a targeted oral medication, berotralstat, which is a once-daily oral medicine that blocks plasma kallikrein activity and, again, has been shown to reduce the frequency of these attacks in HAE patients. So on-demand treatment for everyone, increasingly selecting a long-term prophylactic therapy for many patients. But what's exciting, and as you mentioned, Alina, the standard of care has come a long way from really having nothing to offer these people or offering them very crude medications like androgens, which have lots of side effects. This was sort of a historic treatment for HAE in the US. We've moved to much more effective, much more tolerable, generally safer drugs to manage. And we can put together effective treatment plans for many patients. But we still think there is progress to be made. And so I want to shift gears a little bit now and let's talk about what's coming on the horizon or what investigational drugs are in trials. As noted, most but not all of these are aimed at preventing attacks. And maybe we'll start with the couple of medicines that are furthest along. So we have a couple of medications that are either in or have completed phase 3 studies for the prevention of HAE attacks. And Alina, I'll throw it back to you. Walk us through a couple of these medicines that may be more effective or more tolerable for long-term prophy.
Sure. Thanks, Mark. So one of the newest ones that is still emerging but has finished phase 3 trials is called hereditary. This is a treatment that is a monoclonal antibody, and it targets very early in the bradykinin pathway to something that we call factor 12A specifically. And it's a once monthly subcutaneous administration given regularly in the context of long-term prophylaxis. And the phase 3 trial data are showing that it's going to be a very promising option in terms of preventing attacks. Similarly, there's another drug called donidalorsen. This is what we call an antisense oligonucleotide, and it targets plasma kallikrein, which is earlier in the bradykinin pathway. And also promising data in the phase 2 trial and now the ongoing phase 3 trial showing prophylaxis, long-term prophylaxis, that it's going to provide a lot of benefit to our patients. And so I think those are at least 2 of the agents that we know about. Dr. Rydell, maybe I'll bring it back to you to talk about some of the other ones.
Yeah, and I would just add, as you said, these drugs, not approved yet, but garadacimab and donidalorsen, both looking very effective. I think the the efficacy data for garadacimab is around 87% mean reduction in monthly attack rate. For donidalorsen, we only have the phase 2 study, so a much smaller study, but around a 90% reduction in mean monthly attack rate over the course of these studies, which run for months at a time. So that's number one. As you said, these look really effective. And again, we have effective therapies, but these are right up there with the most effective treatments that we've seen. I would add a couple of things just because we have data, phase 2 or phase 3 data from these respective trials. Not perfect, right? So I always have to remind my patients, even if you're on really effective long-term prophylaxis, you still have to keep your rescue medication around. So I think that's always, at least for the foreseeable future, on-demand treatment is not going away as something we have to make sure our patients have, even though they're likely to need it very infrequently with these newer prophylactic treatments. And the other thing, as you mentioned, Alina, is that these are medications, donidalorsen and garadacimab, that in the trials have been dosed less frequently. So monthly, I think both of them are either every 4 weeks or once a month. And we do have, there's a little bit of data from donidalorsen. Again, it's phase 2 extension data, but showing some patients have very good efficacy, even dosing every 2 months. And so this is a trend we're seeing to try to push out dosing, make the schedule of medication use less burdensome, more tolerable, and reduce the burden of treatment while still maintaining great efficacy for preventing attacks. You mentioned some other programs looking at prevention, and I would say there is oral medication that's being studied, a medication called deucrictibant, which is a bradykinin 2 receptor antagonist. So it blocks the B2 receptor and therefore prevents the vascular leak caused by excessive bradykinin production. That study is just completing phase 2 studies for prevention. So we don't actually have a lot of data yet, but we're looking forward to hopefully seeing that before too long. But this would be an oral way to prevent attacks. We have one oral medicine, beryl-tralstat, that's approved. This would be another mechanism of action through a pill that might be able to prevent HAE attacks effectively. And then the other big, I think, topic for prophylactic therapy in HAE is gene therapy. So I'll say a few words about this, but interested to get your thoughts, Dr. Banerjee, on gene therapy for HAE. A couple of approaches that have now started human studies, and these are phase 1-2 trials, so very early in the development process, but in people being studied in individuals with HAE due to C1 inhibitor deficiency. One is AAV therapy. This is, of course, taking the genetic material that generates C1 inhibitor protein, the DNA, putting it in a viral vector, infusing it in the patient where it goes to the liver, and ideally, then this translates to increased C1 inhibitor production. This has only been done in a few patients so far, and we don't have a lot of data yet to know how effective that's going to be. But it does appear after a couple of doses in about 4 patients that there have been some increases in the plasma C1 inhibitor levels. And so we need more data to know whether this will be a viable therapy, but potentially increasing C1 inhibitor production through gene therapy to prevent attacks. And then gene editing. So CRISPR-Cas9 therapy, in the case of HAE, this is targeted actually knocking out the gene that makes plasma kallikrein or prekallikrein. And if you knock that down, you cannot make excessive bradykinin. Again, plasma kallikrein being the protein that generates bradykinin for the most part. So we have some early data on about 10 patients that have undergone this gene editing treatment. And so far, it does look like it can effectively knock down plasma kallikrein production and activity. And this has translated to a significant reduction in HAE attacks. So far, with the early data, on average, about a 95% reduction compared to baseline attack rate for these small number of patients. So Alina, interested in your thoughts on maybe particularly gene therapy, but any of these things that we've talked about, how you see this playing out, and what your thoughts might be.
Thanks, Mark. It's an interesting area to talk about, because when I think about how I manage my HAE patients now, I've always thought, wow, we have some great treatment options. And I guess you're thinking about when 10, 15 years ago, we didn't have much. But as we keep going, there are so many new therapies in development with very promising results, as you described. And so I think that it is going to make the treatment options, the burden of treatment, the overall goal of helping patients with hereditary angioedema live a normal life become easier. And that's where we're going. So treatments that are, less frequent, they have high efficacy, they may be oral rather than intravenous. And so all of these treatment options are really moving in a way, and even less frequent. And we're talking about this in a context of a condition that's very unpredictable. And so being able to use long-term prophylactic agents really leads to improving quality of life and living that normal life. And I think, as you mentioned, these trials, some are earlier than others, but all of them showing very promising data with good safety, high efficacy, good tolerance of any side effects. And then really the aspect of gene therapy. Both of the companies that are looking at gene therapy, again, very early, but very promising results. Gene therapy, as you know, is being used widely in the field of medicine. And there are many places where we've seen it be very successful. And so I think that there's still a lot of learning around gene therapy that needs to happen to help people, individuals, patients with HAE feel comfortable with the concept of gene therapy. But again, very promising data. And so, Dr. Rydell, I'll bring it back to you. As we, think ahead over the next 2 to 5 years, and many of these therapies will become available, how do you think that's going to change your treatment approach or the treatment landscape for patients that are coming to your office?
Yeah, it's hard to say, Alina, but I think it will change, absolutely. And I think the trends that we're seeing, just as you outlined, this is a chronic, at least at this point, a chronic lifelong disease. We're trying to devise plans that will be tolerable, easier for people to adhere to, and yet maintain excellent control of HAE. And that's kind of the operative word now, controlling the condition. Do people feel in control of not only the condition, but their treatment plan? I think it'll be interesting, as you said, we're borrowing, not borrowing, but we're using same technology that's been used in other conditions, both common and rare conditions, just to add to a couple other options that might become available. We've talked about RNA targeted therapy, so donidalorsen may come along fairly soon, depending on their phase 3 data, as an RNA targeted therapy that can be given, fairly infrequently. There's another program looking at small interfering RNA therapy, which is slightly different, but early studies in humans showing you might be able to knock down kallikrein levels for up to 6 months with a single dose. So we'll have to see if that's safe and effective. But this trend of less often treatment that's less often but still very effective. Monoclonal antibodies, we have one that already, lanadelumab, we're using in HAE. We have another garadacimab that may become available in the near future. There's yet another monoclonal antibody being studied that has a very long half-life, an engineered antibody that could be given perhaps every 3 months and prevent attacks. So this is sort of the trend that I think, is to get back to your question, as we start to incorporate these medicines, if they become available, into practice. I think we're going to have options to discuss what treatments are people comfortable with, what's going to work best with their lifestyle. And I also think we do see a little bit of variability amongst how these drugs work for people as far as efficacy, and also, of course, side effects. Everybody's different, and there may be side effects that affect certain people. So options are good, and I think it's really encouraging to see potentially more and more options coming down the pipeline here. One other thing I wanted to touch on real quickly as far as developing therapies, Alina, is on-demand treatment. We haven't spent much time talking about on-demand treatment, but in fact, there are a couple of programs looking at perhaps other ways to treat attacks beyond the injections or infusions that are currently approved by the FDA. So I don't know if you want to say a word or two about the on-demand investigational drugs that are being worked on.
Yeah, one of the ones that has a lot of data coming out is something called sebetralstat, and it's a oral plasma kallikrein inhibitor, where it's taken at the start of an attack, taken orally. There's rapid absorption, and what they've shown is very quick inhibition of plasma kallikrein with this inhibitor. And so again, it's very early. We still have to see the phase 3 study and the phase 3 data. But for patients who currently have to use either intravenous or subcutaneous treatments, and certainly very limited options in the pediatric population, I think treatments like this are going to be very hopeful, offer a lot of flexibility if you're on a plane, if you're at school, if you're sitting in class, again, with very early data showing high efficacy. So I think that that's going to be a very interesting product that we're going to continue to follow, Mark.
Yeah, so that looks very encouraging. As you said, waiting for the phase 3 data. And then deucrictibant, which you heard before because it's being studied for long-term prophylaxis, also a formulation of that same drug is being studied for on-demand use or treating attacks of HAE. And we only have phase 2 data for that trial or for that compound, but also looked very encouraging. So with both of these oral medicines, at least in phase 2 studies, significantly shorter onset of symptom relief compared to the placebo arm. So seems to relieve people's symptoms fairly fast and decrease use of other rescue medications. So people can, in these trials, more likely just take the pills rather than having to reach for their injection or infused HAE rescue medicine. So as you said, it'll be interesting to see. We need more data, but we may be looking at a world in a few years where people can much more easily and conveniently treat attacks. And some people may opt to do that rather than use long-term prophylaxis. Though, again, I think this concept of predictability of if I take my medicine, I know there's a significant reduction in the risk of having an attack at an inconvenient time or a dangerous attack that could send me to the hospital. I think long-term prophylaxis is certainly going to be a big part of our management plans in the future. Well, Alina, we've covered a lot. Any parting comments? As you said, the interesting part is using all the existing tools, but also these tools that may come along in the coming years. How are we going to translate this to clinical practice? I suppose it's a good challenge to have, but any last tips for our audience on how to think about management?
Yeah, thanks, Mark. I think really just to remind those that are clinicians to be aware of these treatments, to make sure you have conversations with patients, really think about shared decision-making in the context of all of the new available treatment options that are available, and to make sure that it's not a one point in time conversation and that there are ongoing conversations, and that as new treatments and new products become available, that we make sure that our patients are aware of this.
Well put. And the only thing I can add is that we always want to keep our eye on quality of life, right? That we actually are accomplishing what we hope to, controlling the condition with and for our patients, and ideally getting them back to living a normal life, whatever normal is to that individual, that they can pursue the activities that they want to without HAE getting in the way. That's of course the purpose and the goal of any and all of this work that we've been talking about. So Alina, thank you again. A lot of fun. And to the audience, thanks for listening. I hope this was helpful to cover some of the management concepts in the emerging therapies in hereditary angioedema.
Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/HAE4. You can find all of the episodes in this series and all of our other podcasts on your favorite podcast streaming services, or download our Morning Commute app. Thank you for joining us today.